everyone, thanks for joining us today. So before we begin this webinar today, I'd first like to acknowledge the traditional custodians of the land that we're standing on, the Whadjuk Noongar people, and pay my respects to elders past, present and future. My name is Millie Harford-Mills and I'm a research coordinator at the Australian Indigenous HealthInfoNet. So thank you for joining us today. We are joined by our guest presenter, Dr. Julia Butt from the National Drug Research Institute at Curtin University, which is based in Perth, Western Australia. And ENDRI is one of the 3 collaborating centres that we work on with the Alcohol and Other Drugs Knowledge Centre project. So Dr. Butt is a Senior Research Fellow at ENDRI and a practising clinical psychologist. She currently holds a Healthway Senior Fellowship, and Dr. Butt has worked with First Nations drug and alcohol research and clinical practice for the past 15 years, focusing on community-driven research. She undertook a review of Kava use in Australia for the federal government in 2011, and she recently completed a Kava review for the Australian Indigenous HealthInfoNet. So we'll have about 10 to 15 minutes at the end of this webinar today for questions, so we'd ask that you hold any questions until the end. So we'll now switch over to Julia and I'll turn my webcam and microphone off. Thanks, Julia.
Thank you, Millie, and hi everyone. Welcome to today's webinar. I'll try and get it. I'd also like to start today by the traditional owners of the land in which I'm on, which is Whadjuk Noongar country as well. And I'd also like to pay my respects to the elders of Yolngu country. So that's the bottom right picture there is Yirrkala. Today will be about Yolngu people in the Arnhem region. So I think it's important to pay my respects to Yolngu elders, past, present and emerging, and respect that this discussion about today is really about the colonisation and the ongoing, I guess, fight for self-determination for the Yolngu people. So we're going to have a little bit of a journey through Kava today. There's kind of a lot to talk about and not a lot to talk about all at the same time. So it gets a bit confusing with Kava because there isn't a lot of research about this drug, how it works. So it's a bit more difficult than, say, something like alcohol. You can reel off some useful and well-established facts about the impacts. We don't have that with Kava, so in some ways it almost takes a bit longer to talk about. But what I'm going to try and get through today is a bit of a description of what Kava is and uses it, and what are the effects of Kava on health, and that's really from an international perspective. And I've got a little message saying my connection is poor, so hopefully this is still working. And then we're going to talk about Kava use in Australia and have a look at what the research can tell us, particularly now. Where Kava is used, the effects of Kava on health, and the effects of Kava on sort of community more broadly. And then we're going to dedicate some time talking about Kava policy in Australia, and it's a bit of an adventure. So for those of you who are kind of new to Kava or haven't come across it before, Kava is a term describe a plant, sometimes a root, and sometimes a drink. So basically, Kava the plant is a member of Hypothysticum forest F. It grows in tropical Pacific Island countries, and it is not grown in Australia. It hasn't been shown to grow here, so we know that any Kava in Australia is. Mostly we think about Kava made from the roots of the plant. Traditional knowledge through the Pacific, what parts of the plant are used, and it has a long-standing use in Pacific communities. The drink itself.
Sorry, Julia, you're cutting out a little bit. Do you want to try turning your camera off to see if that helps the sound?
Yeah, sure.
Okay.
How's that?
Yeah, so far seems a bit better. Thanks.
Is that okay? Okay, sorry everyone. So in terms of what is Kava as a drink, it's an infusion of Kava root mixed with water or coconut milk. So the way that the drink is made is by pounding up fresh root. That can be, from a traditional sense, sometimes chewed and mixed with water or coconut milk, or just sort of pounded, or used with dry Kava root powder, which is then used in a tea bag sort of method to make a beverage. It's important to note that this is a non-fermented beverage. And it's consumed fresh. Typically, Kava is consumed, I guess, in a group setting, And it's important to keep this in mind. The kava is made and held in a communal bowl, and then it is typically shared around the group of kava drinkers who take turns drinking out of a vessel, which is usually a coconut shell. So it's not a particularly standard size, but it's pretty consistent. It's important to note that this pattern of use means that use is somewhat regulated. People are taking turns to consume the drink, not everyone drinking at once. In terms of what kava feels like, why people, I guess, started to drink this drink is it's a really relaxing drink. People describe it basically in really positive terms, feeling sociability, peace, having a positive mood, reduced anxiety and relaxation. So kava intoxication at a moderate level feels kind of positive. It's important to note that people describe retaining clear-headedness and not experiencing agitation. The taste is pretty bad though, I will be honest. Now, this sort of summary of what kava intoxication looks like is consistent across laboratory settings where people are given kava in controlled circumstances and in ethnographic and participant observation research as well. When consumption increases, so people are drinking high volumes of kava, the muscle relaxation tends to increase and sleepiness increases. So it's described as somnolence and it can lead to really deep sleep. People can experience ataxia, which is a real discoordination or uncoordination of movements, occasionally a sense of unreality, but more commonly fatigue, some dilated pupils and a numb mouth. So basically, as intoxication increases, people get tireder and tireder, more uncoordinated, they fall asleep. In terms of how this happens, we understand these psychoactive properties, so these are the way in which kava works on the brain, is due to something called kava lactones that are sometimes known as kava pyrones. And these are the substance that basically one of the substances people ingest when they drink kava, and it's what gives kava its effect. Kava is absorbed through the gastrointestinal tract, so we drink it and it gets absorbed through the gut. It has a dose-dependent effect on the central nervous system. So the more you drink kava, the more it impacts on the central nervous system. We know that we don't know much, but what we do understand is that the evidence suggests that kava works on the brain by reducing the excitatory neurotransmitters, reducing the excitation, but also increasing inhibitory neurotransmission. So basically what this is saying is that kava kind of slows the brain down, and we understand the effects of kava to be consistent with that. Now kava is being well used in the sort of Western natural medicine field. So people use kava lactone extracts, which are taken using things like ethanol to extract kava lactones from the kava root. So this is very different from the consumption of a natural drink, which is a water-based product. So it's important to note that when we talk about the effects of kava on health, a lot of the research that we can draw from is related to the use of kava for the treatment of anxiety, depression and insomnia, and taken in a tablet form based on these kava lactones. It's important to note that there is an increasing evidence base of the treatment for the treatment of anxiety using kava. So I sort of want to keep that in mind, discuss some of these things. But the doses in which people use kava medicinally is much lower than it's used in a traditional recreational beverage. So let's look at who uses kava. Kava is widely used across the Pacific Islands in Melanesian countries such as Vanuatu and Fiji. And in Fiji, it's used by Fijians as well as Indo-Fijians. It's used in Polynesia, for example, in Tonga and Samoa, but not in New Zealand. And it's used in a few Micronesian countries, but not many. Typically, kava in these societies is used in 3 different ways and has 3 important functions. Firstly, it's used ceremonially, so it's a very important part of a range of different cultural and ceremonial events, and elders' circles, as well as marriages, funerals, and other important events. It's used socially, so for people to get together, and I've just got some spectacular spelling in there. I don't know where that's come from, so I apologise for that. And it's also used medicinally. So traditional knowledge has used kava to treat a range of different conditions across all different countries, and they're quite different. So while we've got to recognise really importantly that kava has fundamental functions in a lot of these communities, there is also a general increase in the frequency and quantity of kava used across the Pacific, and there is increasing concern about the level of kava being used. So we need to sort of bear this in mind, that while culturally kava has significant value, there is emerging concern about the frequency and quantity of use, and also a bit of a growth in use. There are some Pacific nations such as Papua New Guinea who now grow kava who didn't do so traditionally. Kava is also used by the Pacific diaspora, so among Pacific Islander populations in other countries. So we know that Pacific Islanders in Australia, New Zealand and the US use kava. We know that Arnhem Land communities in the Northern Territory of Australia use kava and have done since the 1980s, and that's basically what we're going to be talking about today. Other populations internationally also use kava, both in a traditional medicine sense, but also emerging in the US, the occasional kava social club. So these aren't necessarily Pacific Islander groups, but they're sort of cafes in which you can go and buy a traditionally prepared kava beverage, listen to music and talk. So there are much less regulations internationally on kava than there are in Australia. But putting it all together, the population who uses kava globally is very small. That said, kava has presented itself as a bit of an issue in Australia, particularly for policy. So we have to manage the competing needs of a range of different populations. Firstly, Aboriginal people in Arnhem Land. Since the 1980s, there have been harms documented and associated with kava use, which has presented a policy need. However, Australians with Pacific heritage want continued access to kava because of its cultural significance and importance. There are also consumers of natural medicine who have an interest in the availability of kava lactones as a product. And of course, we also need to consider the economies of Australia's Pacific neighbours, and that also has an impact on the way in which policy is made. So there's a lot of competing sort of parties when we discuss kava use in Australia, which is why it becomes a very complicated little issue. Before we can look at policy, we need to have a look at health effects of kava actually are. Now, this is a really challenging area of research, and it's hard to quickly summarise because we basically don't know enough. We're talking about small populations globally who use kava, and because of that methodological rigour, so the quality of the studies that can be conducted aren't necessarily of a gold standard. There's been great research conducted, but it's hard to compare it across communities. And also we've got to consider in Pacific nations, they're developing nations, and have a vested interest in maintaining the importance of kava for cultural and ceremonial reasons. So it becomes a challenge to sort of investigate it from a health perspective. We also know that we've got this emerging evidence base around the use of kava in natural medicines, but when we look at the research on that, the amount of kava that's used by those populations is very small. There's also a lack of recent Australian data and Australian research. So this has a big impact on what we can talk about today with any confidence. So in Australia, there's basically been very little to no data collected about the effects of kava use in Aboriginal populations since the mid-2000s, and we're now at 2019. So we're looking at sort of 10 years of a lack of research. Make my slide move. Oh, here we go. A number of different international and national organisations have considered and reviewed the research to try and determine whether kava is harmful to health. The United Nations Food and Agriculture Organisation reviewed kava in 2016. The World Health Organisation did so in 2007. And there was also a comprehensive review conducted by Food Standards Australia and New Zealand in 2005. All of these reports conclude that the overall potential for harm from moderate kava use is low. They're only reviewing the evidence that they've got, and that doesn't mean there's no potential for harm, and it also doesn't mean that heavy use is low harm. So there's a lot we don't know, but it's really important to note that using kava at a moderate level does not appear to create any significant health concerns. So if we keep looking in a bit more detail at what the research tells us, we start thinking about what are the short-term potentials for harm. So we talked a little bit before about what the effects are of intoxication. And if you look at that, it's not surprising that there isn't a significant number of harms associated with drinking kava in the short term. We do have concerns that kava is not great combined with driving, and it's possible that ataxia and a lack of coordination could cause you to stumble. So we know that these risks, and probably driving is the main risk there. We know across the natural medicine literature and across the recreational kava use literature that nausea is the main harm or side effect that people talk about. There is some concern with eye discomfort and getting red eyes, but overall the toxicity, well, separate to that, the toxicity of kava itself is considered very low. So in terms of the short-term potential for harm, we know that when it comes to kava, it's relatively low risk. When we look at kava use sort of over the longer term, there are a range of issues that come up. The first one, and the one that we have the most evidence for, is kava dermopathy, which basically is a skin rash that is known as crocodile skin in the north of Australia or kani kani in Fiji. And it's just an uncomfortable skin eruption, and it disappears on kava cessation. So it doesn't last long, and no one's been able to really determine, other than short-term discomfort, what or if any long-term negative consequences occur from the kava dermopathy. There's been a lot of discussion about liver functioning due to some deaths which were investigated related to natural medicine, and since that time there's been a number of reviews suggesting that the original concern that kava had a serious effect on the liver were not founded. But we do know that kava use does affect liver functioning, and it consistently results in the raised liver enzyme, GGT. This then reduces on cessation of use. So we know that when people stop using kava, liver functioning returns to normal. And again, we don't know what the impact of having these elevated levels of GGT are over the long term. So again, don't know too much. It has been shown, particularly in Australia, but not so much in the Pacific, that people who use kava heavily have low body weight, complain of poor overall health, experience low motivation or apathy, and this is a really challenging thing to study, and it's very poorly defined, hasn't been investigated systematically, but we know that it comes up and is discussed a lot. Cognitive function, so the way the brain works and how kava might impact cognitive function over time. Again, there's been a couple of really good quality studies done, but the information that we have from that basically says the effect of kava on cognition is benign, which means it doesn't do much. And I won't go into that in too much detail because I don't want to spend all our time on it. And there has been raised some concern that kava use has been related to seizures. There are a few case studies of this, so whether it's actually a genuine Causal mechanism, we don't know, but if it is, the incidence of Kava-related seizures is quite low. There was a systematic review conducted into the effects of Kava use, not including the natural medicine literature. And basically the systematic review, which was conducted in 2011, and to be honest, I don't think there's many studies to add since 2011, so I consider it still pretty useful information. Basically, causality was indicated, which means that the studies aren't particularly they're not gold standard research, but we know it's likely that Kava causes dermopathy, raised liver enzymes, nausea, and weight loss or low body weight, although it's important to note that the weight loss and low body weight research was not consistent across the Australia and the Pacific. We also know that there's the potential for, and that slide's gone a bit funny, to be honest, but there's an association indicated between Kava and red eyes, poor health, impotence, which has never been shown in Australia, raised cholesterol, low motivation, and an association hypothesis between Kava and having seizures, melioidosis and low immune functioning, and also heart disease. Is Kava harmful to health? Well, to continue this kind of topic, I think the important thing to consider is also Kava dependence, and that hasn't been targeted at all in the research, and we haven't really got a lot of information to discuss this in much detail. But there is evidence to suggest that people do experience some degree of withdrawal symptoms, but we know very little about it, and we don't know much about tolerance either. We also know that Kava does not occur in a vacuum, and the drug interaction effects can occur as well. So Kava and alcohol are both central nervous system depressants, and when they're used together, then ultimately Kava and alcohol have an increased effect on the central nervous system. We also know that there is the potential for Kava to impact on the metabolism of other drugs. As with all drugs, there's also risks associated with practices around the production of Kava, the sale of Kava, and the consumption. So in terms of production, that might be the prevalence of, the presence of pesticides, sale, risks associated with purchasing things from the black market. And in terms of consumption, the main issues that people talk about are hygiene practices around sharing from the communal bowl and sitting for long periods. So in summary, in terms of health, and I know we've probably spent too long on this, and I'll move on to really talking about Australia now, but in summary, moderate use does put people at a low risk for harm. There is insufficient evidence to define what moderate or heavy Kava use is. Some research in Australia has suggested that over 400 grams of Kava consumed in a week puts people at risk for harm. And we don't really know about the chronic long-term, so the long-term effects of heavy Kava use. So this is a little slide from the Fijian Ministry of Health and Medical Services suggesting that we need to drink in moderation, and their argument is that moderation looks like sort of low quantities per occasion, having 2 Kava-free nights per week, and ceasing use if you get a skin condition or eye irritation. So if we turn to Australia now, we know that Kava is used in all states and territories by people of Pacific heritage. The concerns about Kava use and Aboriginal and Torres Strait Islander people in Australia is limited to several communities in the Arnhem Land in the Northern Territory. It's important to recognise that Kava use is not of concern for other Aboriginal and Torres Strait Islander communities. Kava is used in around 8 communities and has been since 1982. I'm not going to name those communities because I don't think it's particularly relevant to the discussion, but people can find that information out. Kava was introduced in a context of social change in Arnhem Land with the increasing prevalence of mining and alcohol being introduced at that time. Kava was introduced following a cultural exchange with Fiji, where Yolngu people spent time with Fijian communities and saw the fellowship that was associated with drinking Kava and the fact that it didn't present that behavioural agitation that comes with alcohol use. So there was this idea that Kava was going to provide fellowship without the harms. In that sense, kava use was encouraged. It was supported by the church, by health organisations and by the government and community. It was considered safe and socially acceptable. So not surprising, kava use rapidly expanded. And what came alongside that was an explosion in the black market. The communities who were bringing kava in were unable to keep up with supply, and very quickly there became a healthy sort of market that emerged. So if we have a look at the use of kava in Arnhem Land and what the research tells us, it becomes really difficult because the research itself is a difficult area. Part of the reason the research has been challenging is because of regulation. So this is a quick look at the Kava milestones. So between 1982 and 2007, you can see there was considerable amount of changing regulation, and research occurs in that context. So because of the changing regulations associated with kava, it makes it really difficult to conduct research that's clean. And also in times when kava is banned, even discussing kava becomes a bigger challenge. There are also lots of challenges associated with research in a small community because these populations are quite small. It's very hard to do robust statistical analyses and all these kinds of things. So in terms of the quality of evidence, it's not considered gold standard, which is not to undermine the research that has been conducted, because a lot of the time incredibly culturally appropriate and good quality methodology, we just don't have a lot of it, or there's been a lot of research conducted on the same small communities that have specific health challenges that are within them. Also, we've got to consider alcohol, and when research has been conducted on kava, many communities had alcohol banned and then reintroduced and then banned, and so there was often a changing dynamic of alcohol in the background, which implicates on health factors quite a lot. There's considerable amount of research between 1982 and 2007, largely conducted by Alan Clough and also by an author by the name of Matthews, who conducted the first study that really comprehensively looked at the health of people who use kava. The research since 2007 is non-existent, so we're talking about old data. At the time in which this data was collected, what we found was that there was over the period from 1982 to 2002, increasing numbers of people drank kava and increasing quantities of kava were consumed. So in the middle of that period, in a kava using community, typically half of all the males were using kava, and they were using at levels consistent with harm. We knew that kava use was more prevalent among males over the age of 40 than any other population, or subpopulation rather. We also knew that people were drinking at very high volumes, so around 2 litres per occasion, and also that they could drink for very long durations, upwards of 10 hours. So that's a considerable time to spend drinking kava. It's important to recognise that kava use doesn't occur in isolation. As I mentioned, alcohol was present and not present, but there's a consistent amount of black market of alcohol availability. Cannabis is very present, and other drugs such as inhalants were also kicking around at the time. So there are a lot of different priorities. We also know that the current extent of we don't know what the current extent of kava use is. There is considerable black market activity still going on, and we know this from police reports and seizures of kava, and anecdotal evidence suggests that kava use is still current, but not at the levels as it was before. So we basically do not know at the current time what the prevalence of kava use in Arnhem Land communities is, but we know that it is remains in the same communities as it always has. In terms of the effects of kava use in Arnhem Land, there's been no systematic evidence for the positive effects. So there have been no studies conducted, rather, that have had a look at the positive effects. So we've got no evidence to suggest that it actually did result in a reduction in alcohol consumption and alcohol-related harms. We have no evidence to suggest that it increased fellowship in communities. But in recognising that we don't have that information, we also can't ignore the anecdotal evidence, because this has an impact on people's understanding of the issues going on and how policy can be made and implemented. So there's still very strong beliefs in community about the relationship between alcohol and kava, and that if kava is taken away, that alcohol-related harms will increase. And that if you keep kava in a community, it will keep people in a community, and males won't leave the community to search for alcohol. So these are really strong and well-documented concerns that community have. But we haven't actually tested these, and there hasn't been sort of robust discussion to sort of challenge some of those beliefs if they're not consistent with the evidence. And it's important that community are really involved in having a look at the relationship between kava and alcohol and whether it even exists, so that we can actually further address alcohol-related harm. Prior to 2002, we knew that kava dermopathy, elevated liver enzymes were common among people who used kava. We also knew that poor overall health was described by heavy kava drinkers, and also by health practitioners blind to kava consumption. So basically, people who used kava were considered to have poor health in general, which is a very poorly defined term, but it was something that was quite commonly discussed. We also know people who used kava had low body mass index, which means that they had low weight. The more people drank kava, it seemed the lower their body fat was. They often reported redness of eyes and poor motivation. There was also raised concerns of immune functioning, the presence of seizures, and cardiovascular health. So it's important that we try and understand these health effects and recognise that they occur in a broader context of complex health needs in the community. Recent information is only anecdotal, and what we do know is that there is much less information now than there was before, and I think that silence tells us that there is probably less kava-related harm now than there was previously. And so it looks as though kava use, or the harms associated with kava use has dropped. In terms of the social effects of kava use in Arnhem Land, in that period of time where consumption was really high, there was significant economic impacts, and these differed between times when kava was licensed and kava was banned. But obviously, having an active black market creates cash drains, and so for individual families, having significant amounts of income spent on kava was concerning. But I think more importantly, or just as important, is time out of role. So if we look at the social effects of kava use, people spent so much time involved in using kava, and whether low health and low motivation was a factor in this or not, we don't know. Less time was spent in cultural activities, less time was spent focusing on one's own health, nutrition and hygiene. Arguably less time was spent caring for children. It was a common concern in reports that have been conducted through interviews with families. Less time in community participation, less time in workforce participation. So basically, people who are using kava really heavily spend a lot of time not doing what they would do if they weren't using kava. Now, if we take these at a community level, I think it's really important. So we've got these health effects that are kind of poorly defined, but we have these really strong social effects around time out of role and the impact that has on family. If you consider that with the prevalence, so more than half of males, or sometimes up to half of the men in a community using, you get a significant impact on community functioning. So while the researchers spent a lot of time on trying to find a health consequence of kava use, ultimately it was sort of the health effects and the social effects emphasised by this prevalence, the really high prevalence of kava use, which has a huge impact on community. So in these small communities, when kava use was at its peak, there was really significant declines in community activities, cultural activities, and things like community cleanliness. Cash drains happened as well, so communities would find themselves very cash poor because a lot of the money had left with the black market. And at one point, Alan Clough tried to come up with a metric to sort of determine when community functioning would be impacted. This hasn't been tested systematically, but I think it's a really interesting idea. And he so if more than half of the men in a community and between 20 and 40% of the women in a community were using Kava and 20% of the available cash in the community went to Kava, then community function would be significantly impacted. And I think when we look at the effects of Kava use on Arnhem Land and why it became such a big issue, it is because of these community effects rather than the specific health effects. If we look at managing harms, during this period, health promotion was available, health screening was being undertaken. These were resourced by communities as best they could. The alcohol and drug workforce in these remote areas is notoriously poorly resourced, and so they had great difficulty in servicing communities for Kava as well as alcohol, cannabis and inhalants. There is a lack of evidence. There is no best practice in responding to Kava use. So what we do in the absence of best practice is best practice in alcohol and other drugs. We need to recognise individual risk factors and recognise the social determinants of health, and that's obviously a broader discussion for another day. But communities did the best they could at managing harms, but they were very poorly resourced and supported to do so. So just to finish off today, I want to have a little talk about the Kava regulation and the supply reduction measures. So basically from a national level, the majority of time and energy in addressing Kava has been quite simply supply reduction measures and supply reduction policy with very little consideration of other factors. So as I mentioned, there's been a lot of policy changes in Kava use in Australia. So between 1982 and 1990, Kava was unregulated. From 1990 to 1993, there was initial Kava licensing system in the Northern Territory. This was terminated in 1993, and Alan Clough described this as a regulatory hiatus. Everything just sort of went silent. Between 2002 and 2007, a second licensing period in the Northern Territory was undertaken. In 2007 until the current time, we have an import restriction on Kava. And quite recently, Scott Morrison announced the possibility of increasing or changing that import restriction. And so we'll just go through some of those as they're quite an interesting little story in policy making on the run. So here we go. From 1982 to 1990, Kava was unregulated in the Northern Territory. There was a rapid expansion at this time of Kava use through communities. And there was also this emergence of a black market. As I mentioned before, even though communities were trying to own and manage Kava themselves, because a demand emerged, so did a healthy black market. Communities did use their own strategies to minimise harm, and during this period, most communities banned Kava at certain times, but they weren't supported to do so, and they didn't necessarily have the resourcing to manage that. In contrast, in Western Australia, as Kava sellers sort of tried to move their way into the Kimberley elders went to the government and requested that Kava was banned, and it was banned in WA up until very recently. In 1990, in response to the emerging harms, and as I mentioned before, these harms are mostly these whole of community challenges, Kava licensing in the Northern Territory was introduced. The goal of this is to reduce consumption and introduce the responsible sale of alcohol. So what this looked like was there was one wholesaler of Kava and communities could apply to have retail licenses. This had a real strength in the sense that there was community ownership. There was some challenges in the sense that possession in the Northern Territory was not illegal. So the black market was continued to grow. Thankfully, this period of licensing was evaluated, and the evaluation was conducted by Peter Dabbs, and basically he concluded the objectives of this licensing system were appropriate, but they failed to meet those objectives. There was a lack of responsible sale, and so ultimately there was there wasn't a reduction in per capita consumption of Kava. There was a lack of support to reduce black market, and he recommended improvements including better restrictions on sale and support for funding health and also support for compliance for license check that the Kava licensing were done effectively. In response to these harms at a national level, the Food Standards Committee restricted Kava use, which meant the laws in the NT contravened the Food Standards Act, and so licensing had to end pretty quickly. This was not accompanied by resourcing for health nor policing, and it ultimately meant there was very little understanding of what the laws were, except that the retail licensees were no longer able to sell Kava, and they weren't able to act on the recommendations of the evaluation. Not surprisingly, the black market absolutely flourished during this time, and per capita Kava consumption increased again. In 2002 and 2007, well, actually during that sort of regulatory hiatus, the Northern Territory government put a lot of work into developing a Kava management plan, and in 2002, a second Kava licensing period emerged. There was also a national code of Kava management which aimed to regulate use, but also to ensure the provision for cultural use for Pacific Islander Australians, which was recognised as being very important. And when Kava was banned, that provision was not there. Licensing in the Northern Territory included retail licences, again from communities who were able to purchase from one authorised wholesaler. Communities were able to apply for a retail licence. It included a set price Kava. They had to have boundaries in which Kava was able to be consumed and where Kava was not consumed. They had responsible sale times. So, for example, some communities would have Kava for sale on the evenings from Monday to Saturday, but not on payday. Other communities had different times and days. And so it was a really community consultative approach. Communities decided how Kava wanted to be sold in their communities. The positives of this were that the cash spent on Kava remained in communities and a health advisory group was established. Negatives of this period of time is that it wasn't evaluated, and actually the daily consumption limits under the Kava Management Act were not appropriate, and they were double that considered to be related to the risks of Kava on health emerging. Underage drinking still occurred. The persistent black market continued to grow, and some people were concerned that communities were becoming reliant on the income for Kava to meet the needs of their community. So in a lot of these communities there's very poor resourcing and support, and so the Kava money provided opportunities for communities to do really positive things. During this time though, Kava was still being misused and community harms were still present. But again, we don't know too much about that because it was not evaluated. But there was noise around that Kava was still creating community problems. So at the then Health Minister, Tony Abbott, announced restrictions on the importation of Kava in response to this. These import restrictions basically meant that if you were flying into Australia from a Pacific island, you were allowed to bring up to 2 kilograms of Kava per adult. The decision around this was to allow for the cultural consumption of Kava use by Pacific Islander Australians, but obviously that's flawed because you have to be coming into the country to be able to have 2 kilos of Kava for those cultural purposes. It also meant that licensed Kava ended sort of overnight. The announcement was not made in consultation. Communities were not prepared. The timing was also consistent with the Northern Territory emergency response and a return to paternalistic sort of policy making in the Aboriginal health space. And so this was a real backward step for many communities in the sense it took away self-determination and the opportunity for communities to make changes to their Kava licenses and their Kava plans in relation to the evidence. It was concerning as well, not only because it was disempowering, but it caused immediate impact on community functioning around finances. They did not have enough time to plan to not have Kava-related funds. to spend. And also no provision was made for people who may experience harm related to Kava to have any support from health services. So health services weren't provided with any more resources to address a sudden end in Kava use. They were our immediate negative consequences. We don't have any evidence of how this import restriction has affected things over the long term. The limited anecdotal evidence we have suggests that there has been a decrease in Kava-related harm since 2007. I think the main message we have is silence. Kava is discussed a lot less now, and there is a lot less concern from the health practitioners in these regions around the effects of Kava. That does not mean it hasn't disappeared, and we see consistent seizures of black market Kava by Northern Territory Police, and that provides an ongoing concern for communities. It's also important to note that police are very poorly supported in targeting Kava use, and the black market is only targeted from basically the Northern Territory border. So the other states and territories sort of don't support the Northern Territory Police in managing Kava. It's sort of not on their radar at all. In 2019, so earlier this year, Scott Morrison announced a potential increase to the importation restriction to 4 kilograms. It's not clear what the rationale of that was, but the concern again from Aboriginal communities has been that it wasn't discussed. So community consultation has been sought, and we're just sort of, I guess, in a holding pattern. Whether that community consultation has been passive, please come and send your information to us. That's how it's looked so far, but whether there is plans to actually go into Kava using communities, both in Arnhem Land and across Pacific Islander populations, we don't know yet. We can only hope that it's a more collaborative approach to making policy, and that maybe it's got an evaluation component in it as well, which would be wonderful. So this is just a really quick graph before we finish up to show the implications of policy. So this is basically Alan Clough's best estimate up until 2006 of the availability of Kava. So hopefully you can see there, but basically it finishes in 2002, and it was on the increase then as well. So when it's unregulated, Kava was at its highest, and we could see that under the licensing periods it was also starting to grow, and it was escalating from 2002 upwards as more communities got licenses. In terms of the implications of policy, we know that only licensing has included community consultation, clear objectives and mechanisms to monitor objectives, but both periods of licensing were terminated prior to adjustments being made. Policy changes have typically not been coordinated or supported by increases to health or policing services, and lack of evaluations is worthy of note. And I think also I want to emphasise that policy implementation is an area which can cause significant community harm. So in terms of what we do know that moderate Kava use is low risk. We know that Kava use can cause individual and community level harms when use is heavy and when use is prevalent across the community. We know that Kava use is only part of a picture. It's not the only picture in Arnhem Land communities, and I think it's really important to recognise that. We need to recognise that communities need to be supported to address Kava and other drug-related harm, and that community consultation is required to develop and implement policy. What we don't know is what the current prevalence of Kava use is. We don't clearly know what the harms are or what the mechanisms are for some of the harms that we sort of have limited evidence for. We don't really know what the characteristics of Kava use dependence might look like, particularly in terms of withdrawal and tolerance, and we don't really know what the relationship with alcohol-related harm is or other drugs. So there's no evidence to suggest that when you take Kava away, alcohol use increases and vice versa. It's an area of concern for communities, but we actually don't have the data to discuss that in any detail. In terms of future directions, we need to do more research across cultures as well as cultures, looking at Kava dependence, safe levels of consumption, the impacts of chronic heavy consumption and prevalence. And then just some final thoughts around being more collaborative and actually providing real action and resourcing to support health and policing, and a clearer focus on the social determinants of health. So sorry, I've gone terribly over time. It's always a challenge with Kava because we know so little about it that we end up talking about what the health effects might be for longer to try and work out what the evidence is and to talk about it with some clarity. So thank you for joining me, and if people have questions, I guess I'll hand over to Millie to facilitate that.
Thank you so much, Julia. That was great. Yeah, so if you've got any questions, we've got about 10 minutes now. So if you'd like to ask Julia any questions, you can type them in the chat box. Alternatively, she's got her email on the screen there, so hopefully you don't mind if people get in touch with you, Julia.
Yeah, that's fine.
Yeah, great.
Absolutely.
So if you do have questions you'd like to email her directly, feel free to do that. People do tend to be a little bit shy on asking questions, so don't be alarmed if we don't get any.
Okay.
In the meantime, maybe we can show people where they can access the Kava review and the other resources that we've got on the website.
Yeah, sure.
So what I'll just do is I'll share my screen. So you should now be able to see the Alcohol and Other Drugs Knowledge Centre website. And if you just hover over the Learn tab at the top of the page and then go to the left-hand side to specific drugs and click on Kava, you can see on the right-hand side there we have a section for our knowledge exchange products, and here you can access a fact sheet and a video that are based on the review, and you can access the main review here. In addition, we're also working on a plain language summary version of that review, so stay tuned for that one as well. So we'll give it another minute or two if there are any questions, but otherwise we can wrap up. Oh, here we go. We've got one from Stephen. So he's asking, do the psychoactive chemicals in Kava work in NMDA receptors?
I think you've got me there. Basically, we know that they work, well, the evidence suggests that they work in on the GABAergic system mostly, and there is some evidence that they work in the excitatory area, reducing excitatory neurotransmitters as well, but the evidence for that isn't as good. So I think that's probably the best answer that I can give without going to my cheat notes. But yeah, it's predominantly the best evidence that we have is that it works on the GABA system.
Excellent, thanks, Julia. So it looks like Stephen's just typing a response, so we'll wait for him to write that. So he said, yeah. Thanks. So more GABA than glutamate?
Yeah, it is. We've got a little bit of rat research, but not enough, so we need to do a bit more on brains.
Excellent. Okay, well, if you don't have any more questions, and it doesn't look like anyone's typing, we might wrap it up there. But like I said before, if you do have any questions, feel free to get in touch with either Julia or myself. And thank you so much, everyone, for joining us, and a special thank you for you, Julia, for that great presentation. We really appreciate it.
Thank you. Thanks, everyone, for staying on to listen.
Great. Thanks, everyone.
Bye.